Shin. He worked as a clinical fellow, assistant professor, and associate professor, and have been professor since 2013 at the Seoul Assam Medical Center. And during this period as an assistant professor, he conducted animal experiments on neuropathic pain at the Children's Hospital in Boston and Brian and the Women's Hospital, which is related hospital to the Harvard Medical School, for 1 year. He currently serves as the director of the executive management at the Korean Pain Society, the Korean Spinal Pain Society, and the Korean Neuromodulation Society. He has been working as a professor at the Assam Hospital Pain Clinic in Seoul for 18 years, mainly treating patients with spinal and neuropathic pain, and have published many research papers. We are happy that you made all the way to Dubai. We hope we have a very interesting next contribution from the Korean doctors. Thank you.
Thank you very much for your kind introduction. My name is Shin. I'm glad to be here to introduce the new procedure, the spinal, epidural, balloon decompression, and adhesiolysis. There are two kinds of conventional epidural adhesiolysis and neuroplasty. One is chemical neuroplasty using Ratch catheter. Another is mechanical adhesiolysis using lead catheter or epidural. However, both methods did not have satisfactory results, because they did not have effective mechanical adhesiolysis and ability to alleviate the stenosis itself. The balloon procedure was developed to supplement the disadvantages of the pre-existing procedure and improve the impact. The following clinical trials were conducted to confirm the effectiveness of the balloon procedure. This study on transforaminal balloon decompression was conducted as a randomized controlled double-blind trial and published in the Journal of Pain Medicine in 2013. Inclusion criteria were foraminal stenosis, unilateral reversion claudication, and low or minimal response to other non-surgical interventions, including epidural steroid withdrawal. I randomly assigned patients into two groups. With the balloon group, I inserted the balloon catheter into the intervertebral foramen and performed the balloon decompression. With the Shin group, I inserted the balloon catheter into the intervertebral foramen, but did not perform the balloon decompression. Needle was inserted in a similar way as the transforaminal epidural flow. Then the balloon catheter was inserted through the needle. From this point to here is the area of the vertebral foramen. Decompression was achieved through reparative ballooning and deballooning while slowly withdrawing the catheter. Here are the diagrams of the research. Leg pain, back pain, ODI, and claudication significantly improved over the 3 to 4 months in the balloon group compared to the Shin. Significant improvement in claudication led to higher levels of patient satisfaction. 1 year after the procedure, about 20% of patients in the balloon group showed more than 50% of pain relief, whereas none has been recorded in the Shin group. In order to confirm whether these improvements were actually made through the dilation of the vaginal stenotic area, and if so, how much it actually dilates, I injected the contrast dye transforaminally before and after the balloon decompression, and reconstructed the spread pattern into a 3D image. from this point to here is the area of the vertebral brain. The left image shows the before the procedure. The right image shows the after the procedure. The spreading diameter of the contrast dye in the vertebral foramen increased by about 28% after balloon compression. The spreading volume of the contrast dye in the vertebral foramen increased by about 98%, almost double. In view of these results, it can be certainly said that balloon decompression can expand the marginal stenotic area. There are three kinds of balloon procedures. One is caudal approach, second, transforaminal approach, third is interlaminar approach. This is the this is a catheter for this is the genu catheter for the caudal approach. This is the genu F catheter for the interlaminar and the transforaminal approach. First, let me show the caudal approach using genu catheter. This is a video showing the overall procedure of the caudal approach. After skin preparation, remove the side air of the catheter. Check the balloon. Connect the balloon syringe filled with contrast media to the catheter. After local anesthesia, insert the needle into the caudal epidural space. Needle has to be placed parallel to the caudal epidural space. Inject the mixed solution of contrast dye and lidocaine to perform local anesthesia and epidural graft. This patient has a biliary defect in the right L5 foramen area. Insert the genu catheter through the needle. Advance and adjust the catheter to the right L5 foramen. Insert the catheter tip into the right L5 foramen. After fully inserting the catheter, perform the balloon decompression while ballooning and deballooning. Repeat 2 or 3 times. After performing the balloon decompression, inject the contrast dye and confirm the filling defect, confirm whether filling defect is gone or not. Yeah. After inject the treatment drug, move to other pathology area and perform adhesiolysis in the same way. There are some points to consider when ballooning. Stop the ballooning when the patient complains of severe pain. Do not balloon for more than 5 seconds. The procedure is a repetition of ballooning, deballooning, and moving. Lastly, move the catheter in the deballooned state only, especially in the vertebral brain. By using the balloon function, you can remove a broader adhesion area and alleviate the stenosis directly. So, balloon procedures can further improve the effectiveness and reduce the recurrence rate. If you need, you can insert the epidural scope through the genu catheters. And also, it has the function to place a thin epidural catheter. So, it is possible to perform neuroplasty using hypertonic saline for 2 to 3 days, just like breast catheter. When it comes to target sites for the procedure, if the patient has a symptom of L5 radiculopathy, in the case, the pathologic reason is likely to be the L5 retrodiscal area or L5 brain. So, in the case, I recommend performing the procedure on both L5 retrodiscal area and L5 brain. If the patient has a symptom of S1 radiculopathy or back pain, I recommend the procedure on L5 S1 retrodiscal area or F5 retrodiscal area, especially central area only. The epidural space is divided into two parts. This is anterior epidural space. This is posterior epidural space. If you perform in the central area, I recommend performing the procedure on both sides of the anterior and posterior epidural spaces. This is a hypothesis on how to relieve the compression nerve in the retrodiscal area using the balloon. When the nerve is compressed by herniated disc, insert the balloon catheter to the lateral side of the compressed nerve. The red is the balloon catheter. In this state, if you inflate the balloon right to this, the compressed nerve will be moved inward and released here by balloon. This is a clinical example. The right S1 nerve is compressed by the right L5 S1 disc protrusion. In this case, I inserted the catheter to the lateral side of the compressed nerve and inflate the balloon to relieve the compressed nerve, like this. This is my technique, how to relieve the compressed nerve in the lateral recess of the retrodiscal area. In the normal intervertebral foramen, nerve should move freely like this. However, if there is stenosis, adhesion will be accompanied. Balloon expansion in the intervertebral foramen has the effect of not only alleviating stenosis, but also removing adhesion. This is a video showing inserting the catheter into the left L5 foramen. Advance and adjust the catheter to the left L5 foramen. After fully inserting the catheter, perform the balloon decompression while ballooning and deballooning. Repeat 2 or 3 times. After performing the balloon decompression, inject the contrast dye and confirm dye spread to the filling defect area or treatment area. Right now, dye spread to the left L5 foramen and the retrodiscal area. After injecting the treatment drug, move to the other pathologic area. Retrodiscal area especially, and perform balloon decompression and perform the procedure at the same time, and inject the contrast dye and confirm the dye spread. In the lateral view, you can see the contrast media to spread the anterior and posterior epidural space. This is the balloon. If you perform in the central area, I recommend performing the procedure on both sides of the anterior and posterior epidural space. The catheter is the anterior epidural space. The catheter is the posterior epidural space. You can see the difference. You can perform the balloon adhesiolysis even in the patient who has undergone interbody fusion. In the lateral view, insert the catheter to the anterior first. In the central view, advance the catheter slowly, carefully. Sometimes using the balloon, like this. Carefully, slowly advance the catheter. After sufficiently inserting the catheter, perform the balloon adhesiolysis while withdrawing the catheter, like this. After that, inject the contrast media and confirm eye spread to the treatment area. You can see eye spread to the anterior epidural space as well. Balloon is moving in the anterior epidural space. This is balloon. We conducted this one-year follow-up study. We performed the balloon procedure on all kinds of spinal stenosis, leg pain, back pain, ODI, patient satisfaction. All parameters improved continuously throughout the year compared to other non-surgical interventions whose effect tends to be reversed after 3 months. Balloon procedure using the Shin catheter improved the walking ability, which promotes longer lasting pain. We conducted a randomized multi-center prospective study about balloon procedure involving 3 department doctors in 7 hospitals in Korea. Anesthesiologists, neurosurgeons, orthopedic surgeons participated in this study. A total of 317 patients were enrolled and published in the Journal of Clinical Medicine in 2009. The nature of multidisciplinary, multi-center studies leads to variance in the procedural methods that could significantly influence the study outcomes. To minimize this possibility and maintain objectivity, this study was conducted in a novel way. Once the target sites of the procedure were determined, the balloon procedure was performed at every site. Upon the completion of the procedure, the success or failure of the procedure was marked, as shown in the figure. Target areas were marked based on successful ballooning, and failed ballooning. The markings were then used to calculate the success rate. If 3 out of 5 targets are successful, the success rate is about 60%. After balloon procedure, leg pain, back pain, ODI, and patient satisfaction, all parameters show the same result. When the success rate was more than 50%, the upper 2 lines, pain and ODI were improved continuously throughout the year. However, when the success rate was less than 50%, lower 2 lines, the rate of improvement tended to decrease over time. These results mean that at least 50% of the suspected lesions must be completed by balloon dilation to have a long-term improvement effect. These results indicate how important the success rate of balloon procedure is for long-term improvement. Let me introduce the transforaminal approach using Dusit catheter. This device is suitable for single level and localized foraminal lesion. This is a video showing the overall procedure of transforaminal approach. Insert the needle in the same way as the transforaminal flow. Like that. When the needle tip is reaches the anterior space, like this, in the AP view, insert the genuine catheter. This is the genuine catheter. After sufficiently inserting the catheter, perform the balloon decompression while slowly withdrawing the catheter. After balloon decompression, inject the contrast dye and confirm the dye spread to the filling defect area or treatment area. Yeah. If the patient does not complain of severe pain, it is good to inflate the balloon as large as possible. The larger the size of the expanded balloon, the better it is. If maximum oblique angle, you can insert the needle into the intervertebral foramen is less than 30 degrees. In other words, this angle is less than 30 degrees. The transforaminal approach is not possible. You have to use the interlaminar approach instead. There are two kinds of interlaminar approach: retrograde approach, the same level approach. These show retrograde interlaminar approach. This is one. These show same level interlaminar approach. This is one. The choice of either procedure is determined by which level of interlaminar space is wider. This is a video showing the overall procedure of interlaminar approach. It's very similar with it's very similar with interlaminar block. Yeah, it's different procedure. Insert the needle into the interlaminar space at this angle to opposite foraminal area, while finding the epidural space using Prof technique. After finding the epidural space, insert the TMF catheter like this. After fully inserting the TMF catheter, perform the balloon decompression like this, while slowly withdrawing the catheter. In the latter views, you can see the balloon is in the actuated. Balloon not having to escape. Yeah. Yes. So repeat 2 or 3 times. And inject the contrast dye and confirm the dye spread to the left by foramen and retrodiscal and epidural space. The best indications, in my opinion, is claudication, where adhesiolysis is caused by mild or moderate stenosis, peridural adhesion caused by chronic degenerative disc disease, short duration, less than 1 month, to other conventional interventions, like epidural steroid injection or large procedures like that. Some people are concerned about nerve damage from balloon expansion. According to the review of a number of published journals, it is safe to expand the balloon slowly. The balloon compression of less than 2 hours does not cause damage to the nerve. For the balloon procedure, it is advised to expand the balloon for less than 5 seconds. And to stop the balloon if the patient complains of severe pain. Usually balloon induced mild and moderate pain. However, if the patient complains of severe pain, we have to stop. So if one abides by this advice, nerve damage should not be a major concern. Since balloon procedure was certified as the newest medical technology in Korea in 2013, it has been commonly used in the most large and university hospitals. Recently, it has obtained the CE certification, and and is exploring to Singapore and Italy. Yeah. I personally have more than 9,000 clinical experiences so far, and I am very satisfied with the effect of this procedure. So far, 12 SSI articles related to balloon procedure using gene catheter have been published. I recently published a book contains everything about balloon procedure. I'm sure that this will help you to understand this procedure in detail. You can buy this book on Amazon on Spring Marketing. This is the advertisement from the Korean Pain Society. In November 2024, the International Congress on Spinal Pain will be held in Korea. We invite you, and we look forward to your attendance. Thank you very much for your
interesting lecture about this technology. Are there any questions in the audience?
Thank you for your amazing lecture. My question is, how often you decide to repeat the procedure, and if you look at the long-term improvement, if you do the procedure for more than one time, like, after 1 week or 2 weeks, you repeat the ballooning. This affects the long-term outcome?
Yes, this is non-surgical procedure, so we can repeat this procedure. I started this procedure from 2013. Yes, so right now, sometimes I meet the patients who underwent the procedure in 2013. Yes. So its duration is very hard. Yes. It helps patients walk well. Yeah. So walking itself can promote the patient's symptom improvement and long-lasting effect. So I think compared to other procedures, balloon procedure will long-lasting effect. Yeah. So sometimes the patient have recurrent symptoms, we can perform that procedure again. Yes. However, even if I perform that procedure again, the patient complains of severe pain continuously, no longer improvement, I recommend the operation.
Thank you, Doctor, for informative presentation. My question regarding patient selection for such procedure. Yeah, regarding some foraminal stenosis related to ligamental hypertrophy or facet arthropathy. Is that procedure suitable for such cases?
I'm sorry.
I repeat my question regarding the patient selection. For such procedure, the patient developed foraminal stenosis related to ligamental hypertrophy or facet arthropathy or laminal hypertrophy. This procedure can be suitable to such patients?
According to my other research, so balloon procedure will very effective to the soft stenosis or disc protrusion. If the patient has a very severe stenosis due to hard substance, bone, like that, its duration is very short.
The point is an excellent presentation. It's an innovative technique. which can potentially minimize the use of steroids and use of other issues with credit frequency treatment as well. But can I ask you a question? Sorry, I'm here.
Can you stand up?
Oh, yes.
Yes, it's me.
Can you stand up, please?
Just a question about tolerability of the procedure with patients. I just feel inserting and inflating and deflating a balloon in the perineal space might be quite painful for some of the patients. I heard a big shriek while the video is going on, I'm not sure. But you know, what's your experience? Do you need any extra sedation for this patient? If that's the case, you know, what's the risk of neuropraxia and neural injuries with this procedure? So, thank you.
I told you in the last slide, it's very safe. So according to a lot of papers, some papers say about if balloon can induce the conduction problem. Yeah, sometimes. In the case of usually, if according to one paper, if they compress the nerve using the balloon more than 2 hours, in the case it is the nerve conduction delay problem. Yeah. However, if less than 2 hours, most symptoms is reversible. Yeah. So don't worry about that. So balloon is very weak and can be ruptured, so don't worry about that. And so sometimes it can induce the severe pain. I know, like the video. So I recommend if the patient complains of very severe pain, very specific pain, you have to stop the balloon and release. Yeah. However, if patients complain of mild or moderate pain, you can perform the procedure. It's natural state.
Bernard.
Yeah. Professor Shin, thank you for your wonderful lecture. I actually had some experience with the balloon catheter in Singapore. Just maybe one comment and one question. The first comment is that in terms of the use of the different types of indication, osseous, as in bony stenosis, I find it actually quite hard to get a good result using the balloon catheter. I find that with the intervertebral, this type of stenosis, whereby adhesions may be the cause of the pain, the results are way better. So all the bony posterior element, facet hypertrophy, thickened ligamentum flavum, the results are not that great. That's my own personal experience. And second, the question is that the pressure that is generated in the balloon itself, do we have a maximum? Do we know what's the maximum pressure? That's the first thing. And then I had a few rupture of the balloon itself, especially when I put it into the osseous stenosis, whereby bony bone spur, and it just burst. Is there any way I can prevent that, or is my technique wrong? I would like to hear your comments.
What I saw the last slide, best indication. So I'm sure that if the patient has a very short effect in other procedure, for example, transferring epidural or other procedures, in the case if we perform the procedure to that patient, it's very effective and you can get a longer lasting effect. It is my opinion. So usually I perform the epidural block to the patient before the balloon procedure. So if the patient get a good result, even for a short time, I perform that procedure. Yeah, very good. However, if the patient complains that epidural block is not effective, in the case I try to look for other diagnosis or other treatment.
Thank you.
So it's my indication. And so ruptured balloon is a very big problem. However, for the first time, I am 45 with the very difficult because it's for the first time experience. So, however, ruptured balloon is very safe. So, Korean government gave us allowance. Yes. So, in the future, I'd like to put the device to check the pressure. Yeah. If we get a pressure sensor, we can know what pressure will induce the rupture. Yes. However, right now we don't have that so far. Yes. So I recommend if you inflate the balloon slowly, step by step, we can prevent the rupture a little. Yeah. So, and if patients have very severe stenosis, sometimes we can use the balloon rupture. However, I think it's very safe method, I think.
Thank you very much. I'd like to add one more question following Dr. Bernard Lee, that the bony tissue and the ligament problems, ligament and flavum problems, perhaps not responding that well to the balloon compression. So in your study, did you rate your indications? Because in my experience, those technologies, and it may be better than, for example, radish catheters. I certainly believe that, but I think the main problem for a kind of articular pain is caused by annular tears, for example, from the discus, leaking cytokines onto the nerve root, forming a dense candy-coated tissue. And the candy-coated tissue is from the is going on the nerve root, yes, and to the spinal cord, let's say, and with the beat of the heart, 60 times a minute, it is pulling the nerve, irritating the nerve. And when you do this for 1 minute, that is not the problem. But when you do this 24 hours, that it's like a Chinese torture, you know. When they cut the hair and they drop one drop of water on your forehead, and after 24 hours you have excruciating pain. So this is a kind of mechanism, and of course bulging disc is another very good indication. But can you be a little bit more exact? What were the actual indications from the beta and from the patients you treated?
Balloon can absorb all kinds of degenerative spinal disease. So I believe that this balloon procedure is the last procedure before operation. So if we can get any improvement from this procedure, I recommend the patient to go to the surgery. And even if the patient has not a severe condition, the patient has a neuropathic pain. In the case, I think balloon will resolve that problem. Yes, neuropathic pain. Yes. Yes. So, however, most patients, even if sometimes some patients have a very severe stenosis, however, there is no any symptom from that severe stenosis. It's possible, yes. So sometimes I think these patients will not resolve that with balloon procedure. However, sometimes I have very good result. Yes. So it's possible, yes. So,
Okay. Thank you very much.
Thank you.
Thank you very much.